Hello everyone. So we will be presenting our case study about GERD or gastroesophageal reflux disease. And this case study is prepared by Mr. ALFAFARA Patrick and yours truly, GARDIOLA JHOANA. So for the pathophysiology of GERD is defined as a chronic gastrointestinal disorder that is characterized by the regurgitation of gastric contents into the esophagus. And this is a disorder in the lower esophageal sphincter or less. And it is one of the most common gastrointestinal disorder. And GERD is a condition that causes a burning sensation known as a heartburn. So for the pathophysiology, when we swallow, food passes down through our throat and esophagus or food tube to our stomach. And a muscle called the lower esophagus sphincter or lower esophageal sphincter controls the opening between the esophagus and the stomach. And this muscle remains tightly closed except when you swallow food. So, in a normal person, pag nag-intake tayo ng food or water, there is what we call LES before mapunta sa stomach, yung ini-intake natin. And this is a muscle that open and closes. And sa person na walang GERD, mag-open lang siya if may ini-intake tayo. Well, sa person na may GERD, whether nag-intake ka or hindi, naka-open lang siya. And when the sphincter fails to close, the acid-containing contents of the stomach can travel back up into the esophagus. And this backward movement is called reflux. Kung saan yung stomach acid may enters the lower part of the esophagus. And it then produces a burning sensation, which is commonly referred to as a heartburn. So there are some trigger factors or several factors that might explain why this reflux action occurs. One of this is the position of our body after eating. Next is the size of the meal and the nature of the foods we eat and drink, since they may contain certain substances that may irritate the esophagus or weaken the sphincter, and it can cause reflux. So for the clinical manifestations or symptoms of GERD, there are classic symptoms of GERD such as the heartburn, wherein this is typically described as a burning sensation in the retrosternal area, most commonly experienced in the postprandial period. Next is the regurgitation, which is typically regurgitate acidic material mixed with small amounts of undigested food. And dysphagia, wala dito yung dysphagia, pero kasama siya. It is common in the setting of long-standing heartburn and often attributable to reflux esophagitis, but can be indicative of an esophageal stricture. And other symptoms niya is hoarseness, chest pain, nausea, bloating, bloody or black stools or bloody vomiting, burping, hiccup, dry cough, weight loss, sensation of food being stuck in your throat, chronic sore throat, and chronic spotting. Next is the complications of GERD. So in the esophagus, we have the GERD. And next is erosive esophagitis, the Barrett's esophagus, esophageal adenocarcinoma. So, if yung person is may GERD na, and if lumala siya, pwede siyang mag-lead sa erosive esophagitis, and so on and so forth, like Barrett's esophagus, then yung pinakamalala dun is yung adenocarcinoma. Pag erosive esophagitis pa lang, inflammation of the tissue in the esophagus, wherein yung stomach acid can break down the tissue in the esophagus, which magkakos siya ng inflammation, bleeding, and sometimes an open sore or ulcer. And this esophagitis can cause pain and make swallowing difficult. While yung Barrett's esophagus naman, it is a damage from acid that cause changes in the tissue lining in the lower esophagus. And these changes are associated with an increased risk of esophageal cancer. Or pagkatapos ng Barrett's esophagus, mag-lead siya dito sa esophageal adenocarcinoma. Sa liver naman, we have the NAFLD, or people with GERD may be at a higher risk for non-alcoholic fatty liver disease and cirrhosis or hepatocellular carcinoma. Sa stomach naman, pwede siyang mag-lead sa erosive gastritis and gastric cancer, sa gallbladder, gallstone disease, gallbladder cancer, pancreas, acute pancreatitis, pancreatic cancer, sa colon, diverticular disease, polyps, colorectal cancer, and Clostridium difficile infection sa small intestine, diarrhea, and sa anorectum is dyssynergic defecation. So, yung halos lahat kasi dito, or mostly dito, is complication siya sa obese person na may GERD. So, ito lang yung parang mas yung common sa person na may GERD. Pero pag sa obese, dito, marami siyang magiging complication. So, for the risk factors of GERD, we have the smoking, having large meals or eating late at night, consuming triggered foods such as fatty foods or fried foods, going to sleep shortly after having a meal, and drinking alcohol. Drinking alcohol since it decreases the LES tone, whereas the alcohol has a toxic inflammatory effects on the esophageal mucosa, and it decreases the esophageal motility. While yung coffee naman, it increases the stomach acid production, and due to repeated bouts of reflux, the esophageal mucosa is subject to chemical injury due to the stomach acid stress. And lastly, taking medications without consulting doctor.
Good day everyone, I'm Sean Patrick D. ALFAFARA and I will be reporting about the clinical practice guidelines for gastroesophageal reflux disease. So to start off, the organization responsible in assessing GERD or gastroesophageal disease is the Philippine Society of Gastroenterology. So the Philippine Society of Gastroenterology, also known as PSG, is a component society of the Philippine College of Physicians or PCP. PSG is also a member of the World Gastroenterology Organization or WGO and the Asia Pacific Association of Gastroenterology or APAGE. So for the therapeutic guidelines, we will not dwell on this because it will take a lot of time. So just to summarize these tables. So the treatment for GERD or gastroesophageal reflux disease is categorized into three parts, which first is the antacids, then second is the H2 antagonists or H2 blockers, and lastly is for the proton pump inhibitors. So as you can see in the table, so for the antacids, we have magnesium hydroxide or aluminum hydroxide, then alginic acid and calcium carbonate. For H2 receptor antagonists, we have cimetidine, famotidine, nizatidine, and ranitidine. Then for the proton pump inhibitors, we have omeprazole, and sodium bicarbonate, and lansoprazole. So to keep in mind that the H2 antagonists have a ending suffix called idine or tidine. Then for proton pump inhibitors, they have the ending suffix called azoles or like omeprazole, lansoprazole. It is also indicated in our tables that there are two parts to distinguish within those three drug categories, especially for H2 antagonists and proton pump inhibitors. So as you can see that in the proton pump inhibitor and the H2 antagonist, we have non-prescription and prescription strength um, PPIs and H2 antagonists. So for patient directed with non-prescription proton pump inhibitors, they are taken once daily. Then for non-prescription H2 receptor antagonists, they are taken twice daily. And as you can see, why they are a frequent there is a frequency in their dosage is it because they have low dosing or low dosage or concentration of the drug. So as we go on, as you can see that the prescription strength for H2 receptor antagonists that lasts for 6 to 12 weeks of treatment, we could see that the dosage has been increased. So that is why we should consider that when a drug is in a prescription or needs a prescription, their dosage is sensitive and need to be cautious. That is why they need prescription in order to get these drugs. So here again, so you can see that the prescription strength proton pump inhibitors has also increased in dosage. So for the two last tables, you can see that the proton pump inhibitors and the high dose H2 receptor antagonist has a really high dosing, especially these drugs is used for GERD with atypical or alarming symptoms. So in order for these drugs to be given to a patient, first they have to undergo diagnostics to identify if these drugs are the appropriate ones to be used. Like they need to have an endoscopy or biopsy to evaluate the intestinal mucosa. And as an add-on, you can see that the lower part has an interventional therapy, which is the anti-reflux surgery.
Actual patient case. Case on gastroesophageal reflux disease. WR is a 75-year-old male with a significant history of GERD. He presents to the family clinic today for a routine follow-up visit. The patient reports that during the past 3 weeks, he has experienced increasing episodes of postprandial heartburn with some regurgitation and dysphagia. He has also begun using antacids daily in addition to his histamine 2 receptor blockers for symptom relief. And despite sleeping with 3 pillows, the patient has also begun to experience frequent nocturnal awakenings from heartburn and regurgitation. So for the subjective or the patient complaint, the patient reported that his acid reflux is getting worse and his histamine blocker isn't working anymore. And he gets a burning pain in the middle of his chest after an hour of his meal. And sometimes he has trouble getting down the food in his stomach and seems that it is stuck behind his breastbone. And he never had these problems before, and his heartburn is affecting his quality of life. For the objective, it consists of the patient information, the lab test results, and patient medication. For the patient information, the patient is a 75-year-old man with a significant history of GERD. The patient is widowed and lives alone. However, his daughter lives in the same town and checks on him regularly and takes him grocery shopping every Sunday. Patient is a retired college basketball coach. He enjoys cooking, traveling, gourmet dining, and playing poker. And his intake of caffeine is 5 cups coffee per day. And he has a history of heavy alcohol use. And his currently consumption reported is 6 beers with shots per week. He has also has a history of smoking, which has which is 55 pack in a year history, and currently smokes 3/4 of the pack per day. For the lab test results, here is his vital signs. VP 155/90, respiratory rate 18 and unlabored, height 5'8", weight 195 pounds, temperature 95.9 Fahrenheit, and pulse rate 75 and regular. And the lab test results for his lungs, heart, abdomen, extremities, neuro, and genital and rectum. And his current medications are verapamil, hydrochlorothiazide, and famotidine.
Okay, now so let's proceed to the assessment based on the information gathered. So for our primary problem list, the number one problem is that the acid reflux has a notable symptoms that the patient is complaining, which are the heartburn, dysphagia, regurgitation, and nocturnal awakenings. And the status of the acid reflux and these problem notes is active. And the second one is the H2 receptor blocker tolerance, wherein the acid reflux doesn't respond to the H2 blocker medication anymore. So the patient developed the H2 receptor blocker tolerance because it is also noted, or it is also known, that H2 receptor is prone to be or to develop tolerance when taken for a long period of time. So for the drug therapy problems identified, for drug-related need, it there are drug therapy problems categorized, which is identified it under effectiveness. So for wrong drug, we consider it as a wrong drug because according to the current medication of the patient for the complaint, which is the patient's GERD. So it is noted that PPI or proton pump inhibitors works better and lasts longer than H2 blockers, which are prone to tolerance. So it is indicated that PPI is a better drug when taken for GERD because H2 blockers are prone to tolerance, which in this patient's case, he had or the person has already developed H2 antagonist tolerance. So next is, of course, the famotidine that the patient is currently taking has a low dosage. So, and taking it notely that he or the person is also prone to tolerance as well. So the dosage is too low to have a therapeutic effect for the patient. So famotidine dosage needs a higher dosing to have an effect on the patient's case due to tolerance. So for our therapeutic guidelines or therapeutic alternatives for the primary problems encountered, first we have PPI or prescription strength proton pump inhibitors. So these PPIs are commonly used as an initial and preferred therapy. So it works by shutting down the proton pumps in these cells and preventing the acid from being secreted into the stomach. So the medication availables are dexlansoprazole with the brand name Dexilant, esomeprazole with the brand name Nexium, lansoprazole which is also known as Prevacid, omeprazole and sodium bicarbonate, and pantoprazole and rabeprazole. So for the alternative, we can still use H2 blockers or antagonists, but knowing that the patient has already developed a tolerance regarding the drug class. So we should, in order to make it work, we need to increase the dosage to have a therapeutic effect for the patient. So the higher dosage of H2 blockers or antagonists, this would be an 8 to 12 weeks of treatment, and it works by blocking the histamine receptors in parietal cells to decrease the amount of acid produced in our stomach. So the drugs available for this are cimetidine, which has a brand name Tagamet, famotidine, which has a brand name as Pepcid, nizatidine, and ranitidine. Also take note that in the case where symptoms are relieved, consider maintenance therapy, preferably using proton pump inhibitors. For our pharmacological therapy, First, we have to stop the H2 blockers, which is the famotidine in the patient's case, because they are prone to tolerance, which became the scenario in the patient's case. Because knowing that it was mentioned that H2 or H2 blockers or H2 antagonists are prone to tolerance, especially in long period of medication. Then next is H2 blockers can still be used but in higher dosing. But take note that there are potential risks might arise knowing that the dosing is increased, so the drug strength is also increased, and initial treatment still favors for proton pump inhibitors. For third, we need to switch the patient's treatment to proton pump inhibitors since it poses more effective and duration of action lasts longer. So for our best PPI or best choice for proton pump inhibitor for the patient is the omeprazole and sodium bicarbonate additive or addition therapy, wherein omeprazole is a proton pump inhibitor and sodium bicarbonate is an antacid. So for our non-pharmacological therapies, we should advise the patient to avoid common food triggers like chocolate or sweet things, which is acidic, and caffeine, and also alcoholic beverages. So next is to raise the head of the patient or of the bed for the pillows for 6 to 8 inches in order for the acid be not proportional when you're lying down, that it won't escape or go through the lower esophageal sphincter. So it is also indicated that that the patient should exercise regularly, eat mindfully or moderate eating unhealthy food. Then also don't smoke. Stop eating 3 hours before bedtime because it is one of the common factors or cause why patients develop acid reflux or worse or the chronic one, which is GERD. Because as you know, if we consume food, the stomach produces a lot of acid to compensate in order to digest that food. And if you eat before sleeping, like few minutes or an hour, so you have a lot of acid in your stomach, and lying down would make that acid escape the lower esophageal sphincter, and it will cause acid reflux or the chronic one, which is GERD. So also get enough sleep. Then don't view your reflux in isolation, and sleep on your left side. Why left side? So you should sleep on your left side because on your left side when sleeping, the lower esophageal sphincter, uh, the opening of that would be on the right side. So it would be like when you're lying down, the acid would be on the left side, so it won't protrude on the right side, which will reach the esophagus. So it won't irritate the esophagus, knowing that the acid, it is like curve shaped. Then here is the esophageal sphincter. So if you sleep on your left side, the acid will go here and not protrude here. Because if you sleep on a right side, the acid would go here and the esophageal sphincter is here. So it would irritate the LES or lower esophageal sphincter. So also lastly, avoid highly spicy food because it is acidic and it will irritate the your stomach or your lower esophageal sphincter more. So for the patient education, so in order to educate the patient on what to expect with the medication and expected side effects. Okay, so first is the common side effects when taking medications like proton pump inhibitors would cause headaches, nausea, vomiting, stomach pain, constipation, and flatulence. Then for patient education, take proton pump inhibitors on an empty stomach and eat something 30 to 45 minutes later. Why before and in an empty stomach? Because in that way, the stomach is prepped by the PPI to not produce too much acid. And when the drug is in effect, and then you took up your food, then it won't cause too much acid secretion. So that is the summary or how the mechanism of action of PPIs work. So proton pump inhibitors first thing in the morning unless told otherwise by your doctor. So it is also noted that if you take it in the morning, do it as soon as possible after you wake up, like before shower or brushing your teeth. Then next one would be the H2 blockers or antagonists are most often taken with the first meal of the day. So in some cases, you may also take them before your evening meal, and it takes 30 to 90 minutes for the medicines to work. So the benefits will last several hours. So as you can see that H2 blockers takes a long time to work and also last several hours, but PPI in this case is the best drug to use, knowing that they have a longer duration of action and having a faster um faster to have therapeutic or or the effect in the body. So these are our references used for our case presentation, and thank you for listening, and I hope that you have learned a lot from us. Have a good day.